Hello, everyone. Welcome to this module on mesenteric ischemia. So let's start. Mesenteric ischemia is defined as a medical condition where the small intestine is injured secondary to any process that reduces the intestinal blood flow. Most commonly affects people aged more than 60 years, and the risk factors are atrial fibrillation, heart failure, chronic kidney disease, hypercoagulable states, previous MI. So there are two types of ischemia. It could be acute mesenteric ischemia or chronic mesenteric ischemia, and both presents differently. So let's start with acute mesenteric ischemia. It is characterized by acute onset of severe abdominal pain and is associated with a high risk of mortality. Symptoms start with sudden onset of severe abdominal pain, nausea, diarrhea, abdominal pain out of proportion to physical findings. These are the buzzwords, right? Abdominal pain out of proportion to physical findings and sudden onset of severe abdominal pain. So let's do a question related to acute onset of ischemia. So, a 75-year-old woman with a past medical history of hypertension, peripheral artery disease, migraine headache presents to the ED with a 2-hour history of severe abdominal pain. The patient cannot recall any similar episodes, although she notes occasional abdominal discomfort after eating. She describes the pain as sharp periumbilical pain. She denies recent illness, fever, chill, nausea, vomiting, or diarrhea. Her last bowel movement was normal and was yesterday evening. No fever, pulses 110 per minute, blood pressure 140 over 80, respiration 20 per minute, or beats per minute. On exam, the patient is grimacing and appears to be in significant discomfort. Heart and lung examination are normal. Patient abdomen is soft and non-distended with diffuse periumbilical pain on palpation. There is no rebound tenderness or guarding, and bowel sounds are present. The rest of the examination is unremarkable, and the labs are as follows. All right. So whenever such labs are given to you, you need to find out the anion gap, especially in this case, right? Because you want to rule out any lactic acidosis or ischemia or due to hypoperfusion. So here you see that the lactate is quite high, all right? And what would be the best next step? Or, okay, so you would do a CT angiography, definitely. So this is a bowel ischemia and would prefer a CT angiography. So clinical features of acute mesenteric ischemia, arterial occlusion of superior mesenteric artery, maybe due to a cardiac emboli or a thrombotic event. Non-occlusive ischemia due to hypoperfusion to splanchnic circulation, all right, and superior mesenteric vein occlusion. So these are some of the etiologies related to acute mesenteric ischemia. Clinical presentation, as I said, periumbilical pain with nausea and vomiting, pain out of proportion to examination, all right, and usually there's no peritoneal signs, no guarding, no rebound, like the same way in here, where the patient presents with diffuse periumbilical pain on palpation, but there's no rebound, no tenderness or guarding. Okay, very high yield, and but however, this condition can progress. Okay, so small bowel ischemia to infarction leading to grossly distended abdomen, absent bowel sounds, or peritoneal signs. This is a severe form of bowel ischemia. Okay, and additionally, you do not see any hematochezia in acute mesenteric ischemia. All right, diagnosis will show you a marked acidosis due to high lactate. All right, marked leukocytosis, hemoconcentration, high hematocrit, and also CT of the abdomen and CT angiography can show focal or segmental bowel wall thickening, mesenteric stranding, and portomesenteric thrombosis. Okay, so that is the diagnostic imaging test for acute mesenteric ischemia. All right. So, as we discussed early, there's some of the risk factors associated with AMI is atrial fibrillation or some hypercoagulable states, especially obstructing the superior mesenteric artery or the vein. All right. Now, the progression of small bowel ischemia to infarction leads to gross distended abdomen, and this sometimes can present with bleeding. All right. So that may be a fecal occult blood test positive. All right. And so you always need to have a high index of clinical suspicion, especially in elderly patient with risk factors, atrial fibrillation, peripheral vascular disease. All right. CT ischemia may show signs of small bowel ischemia. All right, and is helpful in excluding other causes of abdomen. All right. So the main thing is a CT angiogram. Treatment involves resuscitation with fluids, correction of the metabolic acidosis, broad spectrum antibiotics, NG tube for decompression. Surgical consultation is also required. Okay. Right. Then this is how you calculate the anion gap. All right. Whenever such a question comes on boards, make sure you do the anion gap. All right. Sometimes the lactate may not be given, so you need to find out the reason uh, for the find out the anion gap. So anion gap is sodium minus bicarb plus chloride. All right. So 19 is a high normal is 8 to 12. More than 12 is a high anion gap, maybe due to metabolic acidosis. Okay. Then so city angiography is definitely always needed. This is in contrast to chronic ischemia, uh, presents with cramping abdominal pain after eating. Okay, this is with the chronic mesenteric ischemia. And patients with acute mesenteric ischemia generally do not demonstrate peritoneal sign initially on an examination, but will often have grossly bloody stools if they develop any peritoneal signs later. Okay, so that was all about the acute form of mesenteric ischemia. Now moving on to the chronic mesenteric ischemia. So it's a gradual decrease of blood flow, typically associated with atherosclerosis, and is characterized by postprandial abdominal pain with unintentional weight loss and food aversion. So every time a patient presents with, have a complaint of abdominal pain after food, so this results in food aversion and in turn unintentional weight loss. So postprandial abdominal pain that resolves, otherwise known as intestinal angina, and this is this is how the questions are presented in the exam. And food aversion, weight loss with an abdominal bruit. Okay, so let's walk through a question related to chronic mesenteric ischemia. So a 67-year-old man presents to the ED with abdominal pain, and the patient states that whenever he eats, he gets diffuse abdominal pain and experiences nausea, vomiting, and diarrhea. He states that the pain is mostly in the epigastric region. As a result of the pain, the patient has begun to eat less and has lost 10 pounds. And medical history is notable for diabetes, hypertension, dyslipidemia, and a 30-pack smoking history. This is quite extensive and important, right? And blood pressure is high. Oxygen saturation is normal. Physical exam shows non-tender abdomen. The patient states that his abdomen pain mostly resolved by the time he arrived to the ED. Which of the following is the pathophysiology of the underlying disease? It's atherosclerotic vesseling of the vessel narrowing, right? So, so this is how exactly the chronic mesenteric ischemia presents. This is intestinal angina. It's a postprandial pain resulting in a food aversion and weight loss. Okay, especially with a history of diabetes, smoking, dyslipidemia. Okay, now therapy is dependent on the etiology and can be pharmacological or surgical. Okay, so a non-occlusive mesenteric ischemia, you treat with IV fluids, NG tube decompression, anticoagulation regimen if needed. All right, vasodilators, example piperacillin. Occlusive mesenteric ischemia, surgical revascularization via angioplasty and thrombolytic therapy. Emergent laparotomy if there is bowel infarction or necrosis. All right, so this is another question. The summary is that any patient who presents with a ischemia, bowel ischemia, you would do an abdominal angiography. All right. So abdominal angiography, CT angiography or MR angiography, duplex ultrasound are all non-invasive means of making the diagnosis. Angiography remains the gold standard for making the diagnosis, and intervention with angioplasty and or stenting can be done in the same setting. Okay, so this is all about ischemia, acute and chronic mesenteric ischemia. Thank you so much.